Okay, welcome to this session for the Geriatric Health Literacy Active Learning Series. My name is Tony Danuzzo. I'm director of the East Texas Geriatric Education Center. This is the fourth of 5 sessions that we have set up looking at advanced topics in geriatric health literacy. This session will focus on Alzheimer's disease patients and their caregivers. We have quite a variety of presentation material and activities that we're going to be providing. You might bear with us as we move things around, and we'll do our best to give directions in terms of what needs to be done. I say active learning because I didn't think we really wanted to have 3 hours of just discussion or lecture. So I like the activities that we're doing. I'd like to acknowledge our partnership with East Texas AHEC. They liaison with us and help us communicate to our large area of service in East Texas. You all have a handout, and these slides are in your handout. We have an agenda set up where we'll be having presentations regarding increasing awareness of the health needs among Alzheimer's patients and caregivers with these 3 topics and presenters that I'll introduce. And then I'm going to do a short presentation on sandwich generation that is a little bit extra and a few videos attached to that. We have evaluation forms that are very important for our program to help us improve as we move forward. We have a session next month that's going to be on June 16th looking at the health needs of older veterans, and also a good presentation on managing the U.S. healthcare system. And as you'll see, that's going to be the grand finale because that will be the last session in this series. And so we hope that you've enjoyed it and have been able to take something away in terms of understanding geriatric health literacy. Today's objectives are listed here. They're pretty straightforward. We're looking at demographics of Alzheimer's disease, increasing skills needed for health providers and those working caregivers that work with patients with Alzheimer's disease. We're looking to identify interventions and resources that are available, very valuable information. We're going to be talking about, again, the sandwich generation, looking at the challenges and discussing some of the strategies that might be able to be used for that population. I'd like to introduce real briefly our teleconferencing sites. We have 4 sites. Okay. Over here we have Stephen F. Austin in Nacogdoches. Okay. And I'd like to acknowledge Mark Scott as the AHEC coordinator for the Piney Woods AHEC in that region. Moving around there and finding their way is Victoria College in Victoria, and acknowledge Jody Sanders, who is the AHEC coordinator for the Pecan Valley AHEC. Coming in and out in this area, they're having a little signal issue, is Baylor University in Waco. And Amanda Thomas for Brazos AHEC is the coordinator in that region. They'll be around. And here we have Lamar University in Beaumont. And I'd like to acknowledge, they all like waving. They're a very energetic group. And Terry Dickerson is the AHEC coordinator for Coastal AHEC in that region. Baylor's here. Ta-da. There we go. I'll be maneuvering lots of things here, and this is something that we're going to be putting up on the screen when we'll have discussion, so that we can bring in those sites that are more than 200 miles away and help them to maybe feel more in the room with us. Okay. Real briefly, I'd like to just let you know that we are offering free CEU credits. We have CME. There are forms on the table that you just need to fill out, and this is for MDs, DOs, nurse practitioners, and physician assistants. If you have any questions, let me know about that. Also, we have CEUs for social workers also available. Okay. Make sure, though, that you sign in. Use sign-in sheets for that purpose, and also fill out the evaluation forms. We're offering C&E credits for RNs. LVNs will receive a letter of attendance. Again, there's a sign-in sheet for that and a special evaluation form and credit request form for C&E. Fill that out, and you'll get your credits. And just let me know if you need any help with that. All right. And also we have CEs for physician assistants and occupational therapists get an evaluation form for that. If you have any questions about that, again, let me know. All right, I'd like to briefly introduce our first speaker, who's going to be talking about the demographics and overview of Alzheimer's disease. Rafael Sampertornet is received an MD degree from the University of Javaniana. Is that correct? Not bad, huh? In Bogota, Colombia. He came here as a visitor, a special scholar with the World Health Organization, Pan Am Health Organization that we now have at the Seeley Center on Aging. And he worked on projects, research projects in successful aging, frailty, and cognition. He's very enthusiastic about geriatric education and curriculum development. He's a scholar in education, and he's provided many lectures for our students to help them become better medical educators. And he's currently a fellow with the Seeley Center on Aging. One other thing I need to say is all our speakers have no commercial affiliations to disclose today. All right. If there are no questions, we're all set to go. Very good. Rafael.
Okay. Good afternoon. I would like to thank Tony Danuso for organizing this session, and Tony and Oma for inviting me to participate. And I'm going to try to go over the basics of Alzheimer's disease and other types of dementias. We have a short time because then we're going to move to the core activity of the presentation. But I'll be around in case for the discussions, in case some questions arise, either from this part of the presentation or from the following activity. To give you a couple of numbers so you can get a sense of what Alzheimer's disease is in the US and especially in Texas. Currently, according to the Alzheimer's Association, there are 5 million Americans with diagnosed Alzheimer's disease. When you look at Alzheimer's prevalence in different age groups, however, you see that this is even more relevant for the older population. So 1 in 8 Americans over 65 have been diagnosed with Alzheimer's disease, and almost 50%, it varies depending on which group you get information from, but almost 50% of adults over 85 are diagnosed with Alzheimer's disease. This number will definitely increase. The projections is by the year 2050, 14 million Americans will be diagnosed with Alzheimer's disease. And currently, even though there have been some very exciting and important advances in molecular research related to Alzheimer's disease, we still have no cure, and the resources we have available for prevention and management are there, but they're not where we would want them to be. They're not as good as we would want them to be. Costs related to all dementias account for almost $148 billion per year. I'm using Alzheimer's as an example because it's the most prevalent type of dementia, but there are at least 20 other types of dementias that could be diagnosed related to other conditions that present in a different way to Alzheimer's disease and that required a slightly different treatment. However, most research right now is dedicated to Alzheimer's disease because it's the most prevalent type of disease. So if you have questions about other types of dementia, maybe later in the discussion or in future meetings, we could discuss about other types of dementia. But today I'm going to focus mainly on Alzheimer's disease, but I'll try to differentiate when I'm talking about the groups of dementias altogether. So to care for those dementia patients, we have 10 million caregivers, and 1 of every 3 caregivers is 60 years and older. So that means that, as we saw before, they're getting to the high-risk age. So there are some cases where you have a caregiver, they're starting to have memory problems that is caring for an Alzheimer's patient, which brings a whole new set of questions and difficulties to the situation that this specific patient is going through. In 2005, it was calculated that unpaid caregivers, spouses or family members mostly, provided 8.5 billion hours of care that were worth $83 billion. So this poses an interesting question that how are these family members supporting for themselves while providing care for Alzheimer's patients? But that's part of another discussion. But this gives you at least an overview of how much caring for an Alzheimer's patient can cost and what implications that might have for a family member. And usually caregivers are the ones that accompany the patient on the health professional visits. So this is very important because they are the ones that usually provide all the information to the healthcare providers, but also are the ones that have the most information on the patient's current situation. And so caregivers present themselves not only as an essential part of the support for the Alzheimer's patient, but also are the key link between families and patients and healthcare providers. So they play a very important role that we'll analyze further in this talk. So Texas ranks third among all the states in number of Alzheimer's cases. In 2010, 280,000 Texans were documented to have Alzheimer's disease. And for all dementias in Texas, almost 761,000 caregivers provided 656 million hours of uncompensated care that, again, were valued at $7.2 billion. So it's a huge burden to the system cost-wise, but it's, from the social standpoint, is also a big burden for Texans, for Alzheimer's patients, for caregivers, and for family providers. It is projected that in the year 2025, this number will rise to 470,000 Texans with Alzheimer's disease, and therefore the amounts of hours required for caregiving and the costs related to Alzheimer's disease in Texas are going to increase noticeably. And it has been calculated that more than two-thirds of Texans that are in nursing homes have some type of dementia, either mild cognitive impairment going through Alzheimer's disease and other types of dementias. And at least almost half of them have at least a severe cognitive impairment, even if dementia has not been adequately documented or diagnosed. Okay, so I'm going to cover three main topics related to Alzheimer's disease. I'll try to generalize that to other dementias whenever possible. I'm going to start by talking about the stages of Alzheimer's disease. First, I would like to clarify that all dementias have common patterns and common symptoms that individuals present. That's especially true for Alzheimer's disease, even though there are variations on when the symptoms start and which symptoms present first and which symptoms present last. You can see common patterns despite the variation that can be observed. Staging systems started appearing in the 1990s because healthcare providers were noticing that there was not a common language through which we could communicate when talking about dementias. So staging systems are useful because they provide a frame of reference for understanding how the disease evolves, how it presents, and what needs to be done. However, it is very clear from research and from clinical experience that not all patients present the same symptoms at the same time or in the same sequence. So each patient is different despite the patterns that we can see common to many patients. People with Alzheimer's disease usually die between 4 to 6 years of diagnosis, but there is a huge variation between 3 and 20 years. There have been cases documented to last 20 years, and that will give you an idea of how much care a patient needs depending on how long the progression of the disease could last. The most widely used staging system is the Global Deterioration Scale proposed by Dr. Reisberg. And it corresponds widely to what it's usually known as mild, moderate, and severe, or mild, moderate, moderately severe, and severe Alzheimer's disease. So I'll try to show you the overlap. This is just to show you that there are other grading criteria. So there's a clinical dementia rating proposed by the National Association of Neurology that has four. It starts from no alteration to a questionable to mild, moderate, and then severe, but this is not as widely used as the Global Deterioration Scale. So the Global Deterioration Scale has 7 stages. The first stage is where there is no impairment and there is normal function. The second stage, there are difficulties start to appear, and very mild cognitive decline is present. However, some of these difficulties could be age-related, and so this is when a big discussion about where mild cognitive impairment falls into this staging criteria, but I'm not going to go through that. But this is where very mild difficulties are present, and some of them could be due to the age-related changes in how human beings process information and how they react and how their brain works. So this is not noticeable for the patients necessarily. It's definitely not noticeable to family members. And some experts say that with a very careful evaluation, very mild stages of Alzheimer's disease could be detected. Stage 3 is what it's a mild cognitive decline. Friends and family and coworkers begin to notice that there are deficiencies, but most of the time they attribute them to normal alterations due to age. There are very few normal alterations due to age. So whenever a difficulty is noticed, it's usually because it's due to disease, not to normal aging. Most problems present are related to either memory or concentration, the ability to conduct certain tasks or to remember sequences that required a lot of processes. But it's still a mild alteration, and patients usually don't have any functional alterations related to this memory impairments. Stage 4 is a moderate cognitive decline, and this is what people usually identify as mild or early stage Alzheimer's disease. I want to highlight that, as you can see, this is only the 4th stage. There are 3 stages prior, but usually most of us only identify when moderate cognitive decline is present. Stage 5 is where there is severe cognitive decline. This is what we usually call moderate or mid-stage Alzheimer's disease. Memory gaps become larger and more noticeable. There tends to be more complication in other areas of cognitive function, like planning, like orientation. And so the difficulty is more noticeable for both the patient and the family and the caregivers. And functional status starts to become alterated in stage 5. So people have difficulty taking care of themselves and doing basic activities that they didn't have difficulty with before. Then stage 6 is known as the severe cognitive decline. This is termed either moderately to severe or mid to late Alzheimer's disease. Memory difficulties continue to worsen. There are significant personality changes most of the time. Like what I said before, there are variations for each patient. And activities of daily living, basic care activities are a lot more compromised. And then stage 7 is the very severe cognitive decline, is the late stage terminal phase of Alzheimer's disease. And this is when individuals lose ability to respond to their environment, so they're usually bedbound, they can't take care of themselves, they usually have very limited communication with caregivers and family members. So to talk about health challenges and complications related to dementias and especially Alzheimer's disease, I could think of three main areas where challenges and complications appear. One is health challenges and complications to the patient, to the caregiver, and to the healthcare providers or the team that cares for that patient. I'm going to start with complications and then move to health challenges. So when we look at patients with dementias, especially with Alzheimer's disease, there are common complications that are present and that have been documented to be related to the condition. So there is a higher risk and higher prevalence of infections, especially urinary infections and respiratory infections. There are complications of common health conditions that in other patients and in other settings might not cause complications, but given the cognitive difficulty that Alzheimer's patients have, they take a longer time, or they don't know how to express that a certain symptom is present, and so the disease goes longer without being detected, and so complication rates are higher. For example, a myocardial infarction, a heart attack. Patients might not be able to express what they're feeling and what's happening, and so when they're finally taken to a healthcare provider to identify the condition, then it's too late and complications start arising. The same thing happens with urinary infections, for example. The patient might not say that he has urinary symptoms, simply alterations in cognitive status, alterations in behavior start appearing, and that's when the patient is taken to a physician and we diagnose that there is a urinary infection present. Patients with all dementias are at higher risk of falling, at higher risk of fractures, and the complications derived from falling and having fractures for older adults are even more serious for this population. The presence of neuropsychiatric and behavioral problems is also a very important issue for patients with all types of dementias. And that's usually where most of the difficulties for caregivers and family members arises, because of the alterations in the personality and the behavior that the Alzheimer's or the dementia patient usually present with. For the caregivers, there is a big social, a big emotional burden related to caring and living with a person with any type of dementia. And so there are health complications related to this emotional and social burden of caring for someone with a dementia. And so caregivers of Alzheimer's patients are at higher risk of having heart attacks, of overseeing their health as an important issue, so they stop exercising, they don't eat well, and they have other complications related to not leading a healthy life. They're at higher risk of depression and other psychiatric conditions. And recently there's been a lot of discussion of exhaustion and caregiver burnout and caregiver burden related to caring for a person with Alzheimer's disease and other types of dementia. So the health risks for caregivers are real and are far more important than simply saying that it's hard from the emotional point of view. There are medical conditions that they actually are at higher risk of suffering and getting complications from. And there are actually no complications that I could think of related to the healthcare group as a group, because I couldn't think of any complications that a group could experience secondary to Alzheimer's disease. And to talk about health challenges also, in the initial stages for patients, for example, they notice that they're having difficulties. So there are health challenges related to noticing that I'm losing ability, I'm losing the possibility that I can of caring for myself, of doing what I had planned to do. So there is a big emotional internal problem related to noticing that you might not be able to care for yourself and to be independent for a long time. There are also challenges related to deciding, okay, I know this is a disease, there is no cure, so I want to start getting my things organized and telling my family what my wishes are, talking about advance directives, talking about a series of health issues that pose difficulties from the emotional and social point to the patient. For caregivers, there is a big emotional burden, as I said, that poses a lot of health challenges, deciding where mom or dad are going to go when I can no longer care for them, deciding when the point to decide of, okay, I have to start making decisions for mom and dad because they can no longer make those decisions. Driving issues, for example, in a state like Texas where public transportation is non-existent, deciding when mom and dad have to stop driving is a big issue that caregivers face. And challenges for the caregiving team are numerous and vary a lot depending on which discipline we're talking about. For social workers, for example, guiding families and helping families in all the process of deciding when mom is no longer able to decide for herself, about placement issues, about powers of attorney, advance directives. All those decisions pose important health challenges for social workers. For physicians, not all physicians are trained to deal or treat dementias. For those few that have received the training to manage patients with dementia, the health challenges are related to quality of life and quality of death. For those not trained is trying to manage a disease that is very difficult to manage and that requires a long time, a lot of training, a lot of dedication to the families, to the patients, and to the system, to navigate the system. And in general, there's a lot of different unique health challenges for each member of the team, but the team as a whole tends to work better and deal with these health challenges when they work as a team and when a team is organized in the early stages of dementia, because then the progression can be followed and patients, families, and healthcare providers can work together to help in this process to improve quality of life and ultimately quality of death of dementia patients. Now I'm going to turn this over to Oma Mori.
I'm going to make just a bit of an adjustment on what we're doing here because of time, and just introduce myself real quickly. I'm Oma Mori. I'm with the Office of Educational Development, previously with geriatric education here and at Stanford. My research and my focus and interest has always been on working with dementia and Alzheimer's caregivers. So you're going to see a little bit of that come out in what we're doing today. We're going to do something just a little bit different than we normally do. And we're going to have a reader's theater production. In your handouts, and I have slides, but I'm going to just let you look at this instead, there's information on health literacy. One of the things is that Dr. Tennant was very good at talking about was the issues around the patient, the stages the patient goes through, and the issues around caring for that patient. I'm going to kind of look at it from a little different perspective and the caregiver themselves and the issues. When we look at health literacy, we have to realize that with a dementia patient, we're not only dealing with the patient, we're dealing with the family's members' understanding. So it's always usually at that point of them not being able to care for themselves, working in a triad between the physician, the caregiver, and the patient themselves. We're going to be putting on a 30-minute Reader's Theater production up here based on qualitative research that I've done with a study on Alzheimer's care and dementia caregivers. This was part of a 2-act play that was produced. I know some of you here have seen it, but 2-act play that was produced here at UTMB last summer. And you will see the main character going through this. Everything you see in here on this is direct quotes coming directly from the caregiver themselves, and so this is all, again, research-based. But I want to give you a role, because as you listen to us and watch us up here, I want you to relate what happens in the play, first off, to those definitions of health literacy, because you're going to see a little different problems in literacy, especially the 4 categories that's right before this slide. I think you will see some of this coming to play. Also, I want you to think about your professional area and what this play says to that. What does it mean to you? How would you, if you were in this situation, be dealing with it from your professional areas? We're going to be talking about this first in small groups and then as a large group as soon as the play's over. and also your thoughts and feelings, anything that you have, any opportunities to improve the patient-caregiver health professional relationships. So at this point, I'm going to let you read over those definitions of health literacy as we set up here for the Reader's Theater.
My name is Corey. I will be playing the part of the narrator, and at this time I will let the actors introduce the characters that they will be playing.
My name is Ruth Finkelstein, and I'll be portraying Nurse 1, Nurse 2, and the administrator. So as I change roles, you'll see me put on a stethoscope and take off the stethoscope, and you'll know when I don't have on the stethoscope that I'm the administrator.
And I'm Kat. I'll be playing the part of Mrs. Andrews, geriatric, and Kayla's mother.
And I'm Omer Mori. I'm going to be playing the role of Kayla Andrews, the caregiver.
I'm Steve Hodson. I play two roles. Jim, who has been providing care for his wife for 8 years, and also Dr. Reynolds, who's a neurologist, and I'll put on a lab coat so you know which is which as I move.
Scene 1. As the play begins, lights fade up on the conference auditorium. Applause is heard as Kayla Andrews steps up to the podium.
This story is about caring for a loved one with dementia. I'm Kayla Andrews, and I cared for my mother for 7 years. Based on my own experience, I believe this may be one of the most difficult and challenging journeys of a person's life. It is a time of great loss and continual grief as you watch the person you've always known all your life die right piece by piece right before your eyes. But for me, it was also one of the most rewarding experiences. I got to know myself and my mother in ways I had never been able to before. When I started my caregiving journey, I had just gotten divorced, moved to a new city, and was working at a job I really enjoyed. I was starting a new life, up for a big promotion to an exciting job, lots of travel, and I had also taken this opportunity to go back to school and finish my PhD. Although my mother and I had always been my time, a time to grow and pursue my own dreams. It was my time to be selfish. I had no idea what was ahead of me. Then I received a phone call from the emergency room at South Hospital. My mother had been taken there with viral meningitis and encephalitis. Her heart had stopped twice in the ambulance. She was alive, but in a coma. Every day for weeks, I sat in the ICU waiting room, hoping that I would once again have a chance to talk to her. Then one day, a nurse came up to me.
Miss Andrews, I think your mother is waking up. Would you like to see her?
Please.
Kayla enters Mrs. Andrews' intensive care hospital room. Mrs. Andrews is in bed, awake, screaming and crying.
Help me. Help me.
Mom, what's wrong?
Mrs. Andrews doesn't notice Kayla.
Help me. Please. Help me.
It's all right, Mom. It's Kayla. I'm here with you. You're okay.
Mrs. Andrews is terrified. She starts moving up and down in the bed, pressing her foot back and forth towards the footboard.
Stop it. Please. Stop it.
Stop what?
Oh, please. Stop the car.
What car?
Stop it. It's going to run over Granny.
What are you talking about? There's no car. You're in bed.
It's going to run over Granny, and I can't stop it. Please, help me. I can't reach the pedal.
Granny's not here. It's just you and me.
Mrs. Andrews continues to cry and press her foot violently towards the end of the bed. Kayla looks around, walks to the wall where Mrs. Andrews is gazing, puts her hands up as if stopping the car, and then begins to move her foot as if she is pressing a brake pedal. Mrs. Andrews cries lesson, and she watches Kayla.
Okay. Look, I'm stopping it. See? I'm stopping it. There. See? It's stopped.
Oh, thank you for stopping it.
Kayla walks to Mrs. Andrews and takes her hand.
See, everything is all right. I'm here with you.
You are the kindest person in this company. Everyone here is so mean.
Well, what's wrong now, Mom? We stopped that car.
Oh, my poor son. He's so busy now, and he has to take care of everything.
What is fine. I'll call him as soon as the sun comes up and see if we can, he can come see you.
He is all alone now. He has to take care of everything. And he doesn't have much money. Please, help me. Please, make sure they bury me where they bury the poor people.
Why do you need to be buried? You're not dead.
Please tell them to bury me where they bury the poor people. He will have a hard time now that I'm dead. And his poor sister, Kayla,
I'm right here, Mom. There's nothing wrong with me. Neither one of us are dead.
Oh, there was a terrible accident. I died. Oh, and my beautiful daughter, she was in the car too, and she died. He is all alone now. Doesn't have anyone to help him.
Kayla tries to hold Mrs. Andrews' hand. Mrs. Andrew hits in the air towards Kayla. Kayla begins to cry and rubs her eyes to hide her tears. Mrs. Andrews notices Kayla and stops crying. Kayla turns away and then turns back. Mrs. Andrews looks her straight in the eyes and begins to cry softly.
I'm sorry. I didn't mean to hurt you.
You didn't hurt me.
You've been the nicest person to me than anybody has been in this poor old place. I am sorry. I didn't mean to give you that black eye.
God, you didn't give me a black eye. Oh, look, see, you didn't give me a black eye. It's just my mascara. You didn't hurt me.
You remind me so much of my dear, dead daughter.
Yes, Mother, I am your daughter.
Kayla hugs Mrs. Andrews as the lights fade. Mrs. Andrews was released from the hospital into a rehabilitation hospital where she spent several months in intensive physical, occupational, and speech therapy, learning how to walk, to feed herself, and to communicate once again. She was then released into a skilled nursing facility. Scene 2. Lights fade up on a nursing home common area. Mrs. Andrews is crawling on the floor, her wheelchair behind her. The nurse tries to get her back into her wheelchair. Mrs. Andrews is yelling and hitting at the nurse.
Don't touch me! That hurts! You're being so mean!
Mrs. Andrews, I need to get you back in your chair.
No, I can walk. I need to go. And I don't want to go in my pants.
We don't want you to hurt yourself.
Mrs. Andrews continues to hit and kick at the nurse as she gets her back in the wheelchair. The nurse then puts a posy vest on her and ties her in the wheelchair.
Please, don't lock me up. I haven't been bad.
We're just trying to help you. You don't want to break your hip.
The nurse pushes Mrs. Andrews to the window.
Now, you watch the birds.
The nurse leaves Mrs. Andrews and walks to the nurse's station.
Why are you leaving me here? Can't someone help me? I haven't been bad. I need to go.
Kayla enters holding a stuffed dog behind her back. She starts toward Mrs. Andrews, who doesn't see her. The nurse stops Kayla.
Miss Andrews, could I speak with you a minute?
Sure. Is something wrong?
Well, we had a little problem with your mother last night.
No.
She was screaming. Something about having to pick up her children from school. She crawled over the bed railings and was on the floor. The nurse tried to tell her that it was the middle of the night and that her children were grown, but that only made her madder. And she started hitting the nurse. So they had to tie her in the bed for her own safety. Then she crawled out of the wheelchair this morning. So we put a posy vest on her so she wouldn't crawl out.
Thanks. Thanks for letting me know.
The nurse walks to the nurse's station. Kayla walks towards her mother. She puts the stuffed dog on a chair.
Help me, please. I have to go, and no one will help me.
Go. Do you have to go to the bathroom?
Oh, yes, honey. They have me locked in here.
Well, let me see what I can do.
Kayla tries to untie the vest.
Nobody will take me to the bathroom. That girl just told me I could go in my pants if I needed to because she put a diaper on me. But honey, I don't want to go in my pants.
Oh, I'm sorry. I really wish I could be here with you.
I know you have to work, and I'm trying to be good. They just don't treat me right.
Kayla becomes frustrated with the posy vest.
I can't seem to get this untied. Let me see if I can get somebody to help us.
Kayla walks to the nurse's station. Lights crossfade from nursing home to small chapel. Jim Thornton, another caregiver, kneels on a pillow.
I don't understand any of this, God. How could you let a beautiful, intelligent, caring woman turn into this monster? Please help me understand why. We didn't create the situation, and it isn't within my power to make Claire well. That's up to you. If there really is a God out there, how could you let this happen?
Lights crossfade from chapel to the nursing home common area. Kayla is sitting in a chair. The dog is next to her. She takes out her cell phone and places a call.
Where are you, Mark? Hey, it's me. I'm at the nursing home. I wanted to tell you they offered me the promotion today, but with 75% travel, how can I do it with Mom?
Jim enters and crosses to Kayla.
Look, call me when you get this message. Jim, it's Kayla Andrews. I met you at the caregiver support group meeting.
Yeah, I'm sorry. I'm a bit distracted today.
Is your wife all right?
No, not at all. It's horrible. She's been violent with the staff, so they have this cage, a fishnet cage thing around her bed so she doesn't hurt anyone. I don't know if she knows me at all. I go into her room and all she says is, "Leave me alone and go to hell." Now Claire stopped eating, so the nurse is called in hospice.
I'm so sorry. My mom is in room 10. Look, if there's anything I can do, please let me know.
Thanks.
Jim exits. The nurse enters, pushing Mrs. Andrews in a wheelchair. Mrs. Andrews is crying.
Your mother took care of her business.
The nurse leaves Mrs. Andrews with Kayla and goes back to the nursing station.
Why are you crying? Didn't the nurse help you?
I can't remember his name. What's wrong with me?
Whose name?
My husband. I loved him so much, and I can't remember his name.
His name was Howard.
Howard. I loved him so much. I don't like it here. I want to go home.
When you get stronger. But for now, I have something that might help.
Kayla hands Mrs. Andrews the stuffed dog. Mrs. Andrews cuddles it.
Oh, honey, he's so cute. I'll call him Howard. Are my roses still blooming?
Oh, I think there's still a few left. Would you like me to bring some up to you?
I would love that. I am really sorry that I've been such a problem to
You
you.
are not a problem. You know I love you.
I know you do, but you're always here, and you have so much work to do for your school. I don't want to be a burden on you. I want to see you graduate. I want to see you become a doctor. Promise me you won't quit.
Okay, I promise. But for now, you better get some sleep and I'll be back tomorrow.
You won't let them tie me up, will you?
I'll see what I can do.
Will you say the prayer with me before you go?
Sure.
You start it for me, okay?
Okay. Our Father,
Our Father,
who art in heaven,
who art in heaven,
hallowed be thy name.
hallowed be thy name.
Thy
Thy kingdom come. Thy will
be
will
done,
be done
on
on
earth
earth
as it is in
in
heaven.
heaven.
Give us this day
this
our daily
bread,
bread, and forgive us our trespasses as
We
we
forgive those who
trespass against us.
us.
And lead us not to
into
temptation,
temptation,
but
deliver us from evil. thine is
the kingdom,
and
the power, and the glory,
forever,
forever, ever and ever. Amen. Thank you.
Now, let's get you to your room, and I'll see you tomorrow.
Kayla kisses Mrs. Andrews and starts to push her to her room as the lights fade. The following day, Mrs. Andrews goes into a grand mal seizure. She is taken to the emergency room, where she is once again lapses into a coma. 2 weeks later, Mrs. Andrews is again released to a rehabilitation hospital for therapy. Dr. Reynolds is a neurologist, follows her while she's there. Scene 3. Lights fade up on her room in a rehabilitation hospital. Mrs. Andrews sits in her bed, her stuffed dog by her side. Kayla enters.
Have you seen my handsome doctor yet?
I have.
Isn't he so good looking? I really like him.
Oh, he is very nice. I like him too.
What's his name?
Dr. Reynolds?
Dr.
Reynolds.
Reynolds. Have you seen him yet? He's really good looking.
Dr. Reynolds enters Mrs. Andrews' room holding a chart.
Hello, Mrs. Andrews. And how is my favorite patient doing today?
I'm fine.
Well, that's just great.
Dr. Reynolds pets Mrs. Andrews' stuffed dog.
Now, he doesn't bite, does he? Hello, Miss Murphy. It's good to see you again. Your mom is looking much better, isn't she?
Oh, she does look good.
She's been having a few seizures today, so I'm going to watch her closely. But right now, I need to ask you a few questions. Is that all right? Okay, now some of these may seem a little silly, but you just pacify me because I want to get you out of here, okay? Do you know what today's date is?
You know, I've been here for a long time. I really don't remember.
That's okay. Half the time I have trouble remembering the date. Do you know what day it is?
I'm afraid I don't know that either.
Okay. How about the year? Do you know what year it is?
19 and something, I think.
That's good.
Oh.
Do you know where you are right now?
I'm here with you.
That's true. Do you know what place you're in?
Oh, I guess it's the hospital.
Mm-hmm. Do you know which hospital?
Oh, it's the one my daughter brought me to.
You're in the rehab hospital. Do you remember coming here?
No. How long have I been here?
Almost a month now. I have another question for you. Do you know who the president is?
The president?
Mm-hmm. The president of the United States.
Oh, let me think. I can't remember his name, but he's really good looking, and I voted for him.
Before she left the rehabilitation hospital, Mrs. Andrews lapsed into yet another coma. Dr. Reynolds is intrigued with Mrs. Andrews' case and decides to follow her as her primary neurologist. It has now been almost a year since Mrs. Andrews' first coma. With each coma, her cognitive function continues to decline. Previous to this last hospitalization, Mrs. Andrews saw another neurologist who had diagnosed her with seizure disorder and early stage dementia, probable vascular and possible Alzheimer's. Mrs. Andrews' behavior problems also increased, causing a multitude of problems in long-term care facilities. She has been in her current facility for over 6 months. During that time, she was sent to a private mental hospital where she remained for 3 weeks as they attempted to adjust her medications. The hospital ultimately released her, indicating negative drug interactions between her seizure medications and her psych drugs. Although she remains on lithium after returning to the nursing home, the dementia progress and her behavior problems increase. Scene 4. Lights fade up on a small office. The nursing home administrator is sitting behind a desk. Kayla sits in a chair across from the desk.
Thank you for coming, Miss Andrews.
Well, I've wanted to talk to you too. I've been really upset about how my mother's been treated.
I did receive a call from the ombudsman about some of this, I'm sure, but go on.
Well, first, you have 70 on the first floor alone, and for weeks there's only been 2 aides working the floor at night. It's been over a week since my mother's been bathed.
You know, we are short-staffed. As are all the facilities in this area. Go on.
Well, I guess that's why no one is able to help her go to the bathroom when she needs to use the toilet.
The administrator writes notes, seeming to ignore Kayla.
Also, twice when I visited, she was tied in the bed with a posy vest. The first time she had scooted down in the bed and almost hung herself. The second time, someone twisted the posy vest like a rope, tied it around her stomach and then to the bed rails. It was so tight it was cutting at least an inch into her stomach. She was stripped naked and wet. I couldn't untie her, and the nurse had to cut it off with the scissors. What if there had been a fire?
Miss Andrews, you know your mother is impossible to manage at times. We try our best, but we're just not set up to handle her problems. Maybe you need to take more responsibility.
Well, I would love to care for her at home, but I was told she needed 2 caregivers 24 hours a day due to her behavior problems. Even if I took the role of one of the caregivers, it would still cost me over $140,000 a year for her care. Where am I supposed to get that kind of money?
I'm sorry, but that still doesn't resolve the issues she is having here.
Well, after she moved in, you said she needed psychiatric care. So as soon as she had a clear moment and could sign herself into the psychiatric hospital, she went. For 3 weeks, they just kept adjusting her meds, but her seizure medicines reacted with her dementia medicines. I don't know, but so basically what they said is there was really nothing more they could do.
I can certainly appreciate your problems, but I hope you can appreciate mine. Your mother has become a danger to our staff. Today at lunch, she stabbed a nurse aide with a fork because she was upset she hadn't been served food. Luckily, the aide wasn't hurt, but she could have been.
Well, don't you use plastic forks?
We do, but they're still dangerous. You realize her behavior problems are getting worse. I'm afraid she has become a danger to our staff as well as to other residents, and we're no longer able to provide the care she needs here.
So what are you telling me? You want me to move her to another facility?
No, that's not exactly what I'm saying. We felt her behavior required more immediate action since she's a threat to herself and others. So we went into court today and filed procedures to have your mother committed to the state mental facility.
You can't do that. I have power of attorney over her.
I'm afraid we can, and we have.
You've got to give me an opportunity to find another nursing home.
I don't think you understand, Miss Andrews. There isn't another nursing home that will take someone who attacks staff.
Oh my God, I mean, she hit a nurse with a plastic fork. She's in a wheelchair and can't walk. I hardly think that qualifies as an attack.
I'm sorry, there's nothing else I can do. The paperwork has already been signed. This is out of both of our hands.
So what happens next?
The mental police will pick her up this evening and take her to the state hospital. The nurse is getting her things prepared.
The mental police? Absolutely not. She's already confused enough. This is just going to make things worse. I'll take her myself.
I don't think they will allow that.
Look, she's my mother, and I'm not going to let her go alone with some strangers. You can just let them know I will take her. I still have that right.
Lights fade. Mrs. Andrews is sent to the state mental institution. The first day she is there, she has taken off all her medication, including her seizure medication, so they could start her out fresh on new psychiatric medications. That evening, she begins to have the seizures, and she is sent to the emergency room. Once again, Mrs. Andrews lapses into a coma, She remains in the coma for over 4 weeks. During that time, the state mental institution removes her from the facility. Due to her behavior problems, it became increasingly hard to find a nursing home that would accept Mrs. Andrews. However, Kayla did find one. Although they promised to work with Dr. Reynolds, the medical director insisted on being her only doctor and immediately puts her on a psychotropic drug, one she has already been taken off of because it negatively interacted with her seizure medication. After only a few months, Mrs. Andrews goes into another coma, which she remains in for 6 weeks. The nursing home again refuses to take her back. Kayla finds one more facility, one with a late-stage dementia unit. In less than 6 months, this facility also wants to remove Mrs. Andrews, insisting they cannot manage her behaviors. After much struggle, Kayla works out a contract with the facility, agreeing to hire a private sitter if she could not be there. So her mother had someone with her from the time she woke up to the time she went to sleep. Kayla moved across the street from the facility to allow her quick access if she was needed to help at night. The nursing home agrees that Dr. Reynolds can follow Mrs. Andrews for all neurological problems and that he would be the first physician called in those instances. The medical director would be the first called only for non-neurological issues. For the next 3 years, Mrs. Andrews remains in the facility. Dr. Reynolds is able to control her seizures and decrease her behavior problems. For those 3 years, Mrs. Andrews was not hospitalized or in another coma. Scene 5. Late one evening, Kayla is called to come to the nursing home. When she gets there to her mother's room, Mrs. Andrews is in full body convulsions. Her lips are blue due to lack of oxygen. Kayla rushes to her side.
Oh my God, what have they done to you?
The nurse enters and goes to Kayla.
I just left you a message.
How long has she been seizing?
The aide noticed it about 2 hours ago.
Have you called her neurologist?
No, we called the medical director and he
No,
said...
her neurologist.
No, Dr. Sims wanted us to...
You mean she's been seizing for 2 hours and you haven't called him? You're supposed to call Dr. Reynolds for all her neuro problems. The administrator promised.
Dr. Sims wanted us to watch her. I'm sorry, but he's the medical
Why
director.
didn't he send her to the emergency room? She needs something to stop her seizures, and you can't administer those medications here.
Do you want me to call EMS?
Hell yes!
The nurse exits, then returns in a few minutes.
I've called EMS. They're on their way.
Have you called Dr. Reynolds?
No.
I told you, you're supposed to call him for neuro problems. It's in her records. Why? After everything, why couldn't you just call him?
The ambulance is here. You need to leave the room.
I can't leave her.
You have to get out of the room so they can take care of her. You want her to get to the emergency room, don't you?
I'm sorry, Mom. I'm so sorry. I tried.
Lights fade on the nursing home. Scene 6. A hospital waiting room. Kayla sits in a chair quietly. Dr. Reynolds enters and walks over to Kayla.
Kayla, I have to be honest, it doesn't look good.
I know. I don't think I've ever seen her look this bad.
Apparently she was in a tonic-clonic seizure, a generalized full-body seizure, for over 2 hours. Her brain was deprived of oxygen for a while. Also, when she arrived at the emergency room, the ambulance attendants didn't have her medical records. So the ER doctor gave her Ativan to try and stop the seizures without knowing she had an allergy. The seizures seem to be controlled now, so we're moving her to ICU. But I think you need to consider what her life will be like after this.
She didn't have much of a life before. I don't think she's recognized me for the last several months, and you're telling me the quality of life is going to be worse?
She was already in the late stages of dementia. And now, if she comes out of this, she may be in more of a vegetative state. You need to consider that. You know, if there was anything I could do for her, I would.
I know. Out of all this mess over all these years, you have truly been a godsend. I don't know what we would have done if you hadn't been her doctor.
Well, I don't know if I'd go that far. I know we've had this conversation many times before, but your mother has been resilient and always seemed to pull out of the coma. We've discussed her wishes, and you agreed she wouldn't want to live in this condition.
Oh, no, she has a living will. Dr. Reynolds, I trust your opinion. What are our options?
We could continue to give her artificial nutrition and liquid through a tube and see if she comes out of the coma. Realize, however, she may have to continue this type of feeding for the rest of her life. All we will really be doing then is prolonging her death. Or we could start your mother on a morphine drip and remove her nutrition and liquids. We'd move her into a private room so you could be with her, and we would call in hospice. But I want you to think about that before you make a decision. Think about your goals.
No, I know what she would want. Every other time she was in a coma, she wanted to come back. She told me she wasn't ready to die. Even when you stopped her feeding, she came out of it. She wanted to see me graduate. I only wish I had done it before now. No, she would not want to live like this, I know that.
And you? I know you had a difficult time when we talked about discontinuing liquid and nutrition before.
The article you gave me to read really helped me understand, she won't feel like she's starving to death. That helped. But to be honest, I don't know if I'll ever be ready to let her go. But she's not really here anymore, is she? This is one of the hardest decisions I've ever had to make. But it's not my life, it's hers. And she doesn't want to be on life support for the rest of her life.
All right, Kayla. I'll make the arrangements. If you have any questions, call me. I'm here if you need me.
Thanks. Thanks for everything.
Dr. Reynolds touches Kayla's hand and then exits as the lights fade. Mrs. Andrews is removed from all life-sustaining procedures. Scene 7. Conference setting from Scene 1. It has been 6 months since Mrs. Andrews passed away. Kayla steps out from behind the podium and walks to center stage.
I'm amazed when I think back over the last 7 years of my life. I am not the same person. When I started this journey, I was pretty much a self-absorbed workaholic focused on myself and my ambitions. But my priorities have shifted and I'm more solidly focused on my values. I realized that some of the most rewarding moments of my life were the times I cared for my mother, giving back to her she'd always given to me. I know I made mistakes, but I also knew I did the best I could with the information I had. I also found strength and courage I never knew I had. I fight for things I believe in. Maybe I'm a fighter because my mother was a fighter. And her love gave me the strength to keep fighting. For the first time, I know what it's like to love someone unconditionally. For I loved my mother no matter what her state, no matter what her behavior she was exhibiting. I learned more about love watching my mother even as she died. The more I think about my experiences as a caregiver, the more I realize the love, the spirit, the faith, the courage and the learning, they're all intertwined like threads woven together to give you strength and keep you moving forward. But most importantly, I did keep moving forward. The day I graduated, I knew my mother was looking down on me and I wanted to say, "We did it, Mom."
Blackout. End of play.
I'm going to give all of you just a few minutes if you want to collect your thoughts, jot down any notes, anything you're feeling, anything about your fields. I'm going to excuse the cast because they need to get back to their jobs, but thank you again, all of you, for your help.
Thank you. Michelle Sonia. She's Family Services Manager with the Alzheimer's Association. She received a Master's in Social Work from Our Lady of Lake University in San Antonio. And as I said, she's Family Services Manager in the Houston, Southeast Texas chapter of the AA. She's responsible for overseeing programs that impact caregivers caring for loved ones with Alzheimer's disease and is often a speaker on a variety of topics. I Googled Michelle just to have an idea of like what she's done, and she's all over the place in terms of providing information to caregivers as well as to health professionals regarding the care of Alzheimer's patients. And I'd like to
Okay, great, thank you. One of my passions is working with family caregivers, so it's always a thrill for me to be able to come out and talk to professionals or family caregivers and help them identify how they can better assist caregivers. So one of the things that I've been asked to talk to you guys about is, once you've learned all of this information, how do you tie it in and actually go out there and find the things that the caregivers are going to need that's going to be beneficial for them. So one of the things that we often talk about are support services, because that's what caregivers are looking for. They are looking for additional support, and they're looking for additional guidance because they're so overwhelmed. No matter what disease that we happen to be caregivers for, it's often difficult, and it's often a struggle for us as caregivers to get information. And so oftentimes we find ourselves relying on the professionals that we come in contact with to provide us with that information, or at least to guide us in the right direction. And as professionals, we are looked to as those experts, and we don't often know where all of that information is. So hopefully I can help kind of tie in everything that you've learned today and help you figure out how to utilize and how to find some of those services. So oftentimes what we do is we start looking directly in our backyard. We look within our own community. So within all of our communities, whether it's rural or a larger city, there are some basic support systems already in place community-wide. So some of those are community organizations. Sometimes it's just a matter of finding out where they are within our environment, within our setting. And so those community organizations will sometimes do things like provide Meals on Wheels, which can be a big benefit for families, making sure that their loved ones are fed on a daily basis. Faith-based organizations, many of you may have heard of gathering places. Those are usually done through local churches where they will provide respite care. Usually it's on a monthly basis, and so a lot of families will learn how to kind of piece together different churches, so that they can have a schedule of where they will send their loved ones to. But this is a great free opportunity for caregivers to have a break from their loved one and to know that they're in a facility where there are trained volunteers who can provide some socialization for their loved ones with dementia. Departments of aging. So for those of you who are out in Waco, those of you who are out in other rural areas, usually there's a Department of Aging. Galveston, for example, has the Department of Houston and Galveston. And those organizations typically have funds and have monies that they use specifically for individuals who are over a certain age, typically at 65. And they also have monies for free respite care. They also have monies for having in-home providers come into the home. And as you know, for many caregivers, it's the additional support of having someone to relieve them that they are looking for. There is not a lot of funding per se in the Alzheimer's and dementia world specifically for caregiving. There are approximately 5.3 million people with the disease, and it's been calculated that in terms of caregiving, these caregivers are giving in excess of $1.3 billion of their time. And so there's not specific funds, there's not specific money dedicated to reimburse caregivers, but through our government agencies, they do receive funding where they are responsible for providing in-home care as well as some of the respite care. Many senior service centers have activities specifically for seniors. They're not always dementia appropriate, but if we're talking about someone who is early stage within the disease, who's still able to communicate and who's still able to socialize, it's oftentimes, especially in rural areas, a great way to get them socializing and helping them to maintain part of their independence, as well as maintain some activity and some normalcy to their life before the disease begins to progress to a different level. And then you always have hospital patient education centers. Many hospitals are now being faced with having to deal with a lot more dementia patients, and so they're recognizing a need for education. And they're also recognizing a need not just for professional education, but for patient education. We have the opportunity through the Alzheimer's Association to have quite a few partnerships with different hospitals where we come in and we provide educational programs for individuals who would like to provide education to their professional staff as well as the families that they service. So in terms of services, those were kind of a general idea of what a typical community will have. And when we look at different resources for individuals caring for Alzheimer's, we also look at the different type of care services. So we've got the respite care, and I think most of us as professionals are aware of what respite care is, and it can come in a variety of forms. It can come free through a church-based organization, such as the Gathering Place, or oftentimes you can call your area assisted living facilities, and they sometimes will provide, for a minimal fee, they will provide a respite stay for individuals. Oftentimes I will share with families that it's almost like a hotel stay. You know, if they need to be somewhere or they need a break and they're going on vacation, they can basically check their loved one into the assisted living facility where there's trained individuals, there's secure space for them, and they can leave them there for 2-3 days, whatever the stay is, while they take care of whatever it is they need to take care of. So that is sometimes, for some people, the only option that they may have. So that is available in terms of respite care. Residential care. One of the things that we talk about in terms of residential care for individuals with any type of dementia is that you have to be very careful about the type of residential care that you select. Many people want to, how should I put this? Many people prefer that their loved one be in an assisted living facility because it still gives them a sense of independence. It also allows us the opportunity to not have to confront the issues that are at hand, that this is a progressive disease, that someone will eventually at some point in time need full care. And so we highly discourage against assisted living facilities. And so what we really talk about with families is continuum care locations. So usually with the continuum care location, you will find independent assisted living, and then you will typically find a memory care unit or an Alzheimer's care unit, however they choose to label it. And that way, because what we've learned is that moving from place to place is very difficult for someone with this disease. But if they have to be moved, at least they're moving within the same continuum of care. And as Oma just mentioned, when you move someone from location to location, they're having to start all over again with the nurses, with the doctors, with all of those professionals that they come in contact with. But when an individual is in a continuum care facility, then they're able to transition with all of that information being transitioned with them, with all of that staff being in the same building. So one of the things is that in rural areas, that may be really difficult to find. You may not always find a continuum care facility. So it's important, though, as professionals, that we at least know what the differences and distinctions, what the pros and cons of a family member putting their loved one into assisted facility means. Sometimes you may have to talk to them about looking beyond that and finding a nursing home facility that may have some skill set in working with dementia patients and helping them understand that if someone goes to an assisted living facility and that's all that it is, that one day they're going to get that phone call that says, we're no longer able to provide the level of care that Mrs. or Mr. John Smith needs anymore, and then we're looking at moving. So residential care is one that we come across a lot. when families make that decision that they can no longer care for their loved one. And then we have end-of-life issues. We cannot discuss this disease without talking about hospice and talking about end-of-life issues. Oftentimes, families do not know how to access hospice. There are lots of myths associated with hospice, that it's only for those people that are dying. And so therefore, part of our job as professionals is to understand that Alzheimer patients, because of comorbid situations, may be in pain for a variety of reasons, not because of the Alzheimer's or the dementia. You know, they may have leg issues that are causing them pain. Their arthritis may be overbearing. And so at some point in time, it may be our role to introduce hospice to the families and help them understand that that is part of a service that can help provide support for them as well. So that leads us into, where do we find this help? How do we get this help? You know, this is great information, Michelle, but you still haven't told us anything. So this is what I tell a lot of professionals. When all else fails and you cannot find any information in your area, the Alzheimer's Association is your best resource. Just as you would in your own daily living, when you have issues, you're going to kind of think about, this is my current issue, what would be the best resource for me to start with? So the same holds true when working with families who have dementia diagnoses. You go to the source, which is the Alzheimer's Association. The Houston and Southeast Texas chapter actually services 37 counties. So of the individuals online today, we do not unfortunately service Waco or Victoria, but both of those locations do have a local chapter. For Waco, it's the North Texas and Central chapter, which is through Dallas. And for Victoria, your chapter would actually be the Star chapter, and your closest office would be San Antonio. So what you need to know is that all of these services are available through any Alzheimer's Association nationwide. So the biggest thing we do is we give families information and referral. Many of you will come into contact with families who just don't understand the disease. And unfortunately, as professionals, we don't always have the time to spend an hour or 2 hours helping them understand and answering questions for them. As much as we would love to, the reality is we just don't always have that time. So that is what the helpline does. It's a 24/7, 365-day-a-week helpline that is answered by master's level social workers to help families identify services, to help them understand the problems and the issues that they're dealing with, or if it's just for them to vent and be acknowledged that what they're dealing with is okay, to help normalize the situation for them. So that is the biggest thing. The Houston and Southeast Texas chapter answers anywhere from 350 to 400 calls per month for our service area. So obviously there is a need for this. Education and training. We will go to any community, we will go to any professional setting and provide education and training. I oftentimes go out and do presentations on behavior and communications for family because that is a huge barrier. They don't understand how to communicate and they don't understand the changes associated with the disease. And so oftentimes you hear she's just being manipulative. She knows what she needs to do, she just won't do it. And so helping families understand that it's really not that, it's a part of the disease and that there's a cognitive decline. So we will do that for anyone. We also offer support groups. There's over 50 support groups within the service area in different languages, different themes. We have a men's only support group. We have a support group for early stage individuals, actually for the person with dementia themselves, as well as their care partner. So support groups are very valuable for individuals so that they can identify with other people who are going through this disease process. Then one of my other responsibilities is to offer care consultations. Sometimes families need more than just information and referral. Sometimes there are family dynamics going on. Sometimes there are the brother who's trying to take the money and there's the sister who's trying to take mom to the bank and withdraw the money. And so sometimes we have a need to have a sit down and, as I like to say, a come to Jesus and figure out what the problems are and prioritize them. Doesn't make any sense for us to sit here and worry about what shirt mom is going to put on today when we need to be taking care of the power of attorney. So my job is to sit and assess with them and to help them come up with the game plan, and then to follow up with them and make sure they're following through with that game plan. For individuals with dementia, they're always at risk for wandering. And so we have a nationwide identification program that's either a bracelet or a necklace pendant. We always recommend the bracelet because it takes 2 people to get it off. It's very difficult to remove. But should they wander and drive from Texas all the way to Wisconsin, they can be tracked and they can be reported missing. If they choose to include a photo with their registration, it will also be disseminated across law enforcement, and so law enforcement will always have a photo of what that missing person looks like. And so the family can either report, or a Good Samaritan who finds this person can report and identify that they've been missing. The one thing that I did not add on here that is new is many people ask about GPS tracking systems. There is a recent program through the Alzheimer's Association that is called Comfort Zone, and it is actually a web-based program where individuals can purchase particular devices. So they may purchase like a pager, or they may purchase a vehicle device if someone is still driving. And what one does is logs onto the website, they create a comfort zone. So if you do not want mom walking or driving 2 blocks out of the neighborhood, you set that comfort zone, and when she that parameter, you receive an alert. You receive an alert via email or via text message on your cell phone to let you know that, guess what, mom is in her car and she has drove 2 blocks past her comfort zone, and you can either, one, call a neighbor, or you can leave and go locate her. But it is more of a technologically advanced system than just having the bracelet or the necklace. I don't have a lot of statistics on it thus far because it's a very recent program, but we've had lots of inquiries about it because individuals are looking for additional ways to secure their loved ones and to make sure that they're safe.
Can you use that for teenagers?
You know, when it came out, you know, my first thought was, you know, my child is so loopy and does not pay attention to anything that this would be perfect for him. But, you know, one of the things with Comfort Zone is there's so many other programs. Some of you may have heard of Lifeline. There's one particular program that's associated with the police department that I can't recall. It's something like the Pilot Club or Pilot Project. And one of the things with this particular program is it is specifically Alzheimer's specific. People can actually be booted out of the program if someone finds out that they are not diagnosed with some type of dementia. You know, the other programs are great because they do the job that they need to do, but oftentimes what we find with dementia patients is they've not wandered very far from where they are. And so that's why the whole premise of creating a comfort zone, you know, especially if you know their patterns, if you look at patterns and you start looking at habits and things they like to do. Maybe dad gets up, has always gotten up every morning, got in his car, drove to the local, you know, Circle K, picked up a paper and a cup of coffee. Then he drives down the street to Mr. So-and-so's house and they chit-chat out in the front yard. You know, looking at patterns and some of their rituals and habits of what they like to do really is great in helping you set up that comfort zone and that parameter, whereas the other programs don't offer that. You just kind of go off on a search and hope to find them. So that's really one of the positives. And then of course the downside is not everything is 100% you know, guaranteed. And so I'm sure that we will find out what those flaws are. Certainly research, we're always looking for advocates and advocacy as well. We just sent a huge group of caregivers up to DC who met with different legislators and talked about their stories and shared their stories and their struggles and kind of asked for the different things that they needed. So that's kind of the lesser of what we do. But oftentimes you find caregivers who are very adamant about sharing their stories, and those are the people that we need on our side. So this is how you reach the association, okay? And one of the things is that we have a slew of referral lists that we offer anyone who calls. One of the things was, Tony said, send me referral lists. Well, guess what? There are so many pages. So I'm going to tell you the easiest way to receive that information if it is something that you need. You just go onto our website, which is www.alz.org/Texas spelled out. And there is a link called Helping You. And under Helping You, you will then click referral lists. And all of the referral lists that we have are all there on PDF. If you're not technologically savvy and prefer not to access the computer, you can always call our helpline. You can call the 713 number or the 1-800 number. Now, what I will tell you about the 1-800 number is it will direct you to your nearest location. So if you live in Galveston, but you have a Washington, D.C. cell phone number, it will actually direct you to Washington, D.C. So, because it goes off of zip codes. But that is the easiest way to locate all of our referral lists. There's everything from attorneys, elder law attorneys, to facilities, to geriatricians, to geriatric care managers, about every neurologist, assessment centers, about everything that you need is on that website. And part of it is just the years and years of information of what's been the most helpful for families and what they are looking for in terms of services. And then if you'd prefer not to call or talk to anyone, you do not want to go on the website, then I will give you my direct line and you can call me directly. And that is 713-314-1393. And I am always available to answer questions, or if you have a family that you just feel that you don't have all the information for, then certainly you are welcome to provide them with my number and they can call me and we will help them to the best of our ability. Are there any questions? Did I leave something out or not cover something? Well, great. Oh, darn it. I thought I was going to get away.
On the care consultation.
Yes, ma'am.
Do you go to the homes, individual homes?
Unfortunately, we do not go to the homes. We will do it via telephone or we will do it in office. Unfortunately, my family service staff is all of 3 people for 37 counties. So the concept of going to homes would be fantastic, but we're unable to do that. But if we really do feel that someone needs a home assessment, then we will connect them to, for example, in Houston, I don't know about the other areas, we have a couple of agencies that we have partnerships with where we can refer a client and then they will go in and do a home assessment. Okay? Anyone else? Okay, well that's it for me. You're very welcome.
When we was putting this together, we were thinking about doing a number of different populations that had special needs for health literacy, as opposed to maybe a general patient population. And such as, just an older hospitalized patient, all right, or older veterans. And we're going to do older veterans next month, because I felt that, even though there was a chance of ODing on AD, that there's always something. It's such an important topic. When I do needs assessment surveys, and I ask, okay, what types of topics in aging do we need to cover? What are the issues? What are the important conditions? Always across the board, the top 3, within the top 3 is mental health, and Alzheimer's specifically. So, I mean, along with mental health, there's a lot of psychotropic illnesses. Those other 2 you might be wondering about, falls, and there's kind of a close between diabetes and polypharmacy. But mental health is always there. So there was another aspect of Alzheimer's disease that I was with when a friend of mine sent me a video about the sandwich generation. And I was kind of intrigued by what the sandwich generation was, because I honestly maybe had heard of it, but I really wasn't that familiar with it. And it's relatively straightforward. I'm going to go over what it is, what challenges go on with the sandwich generation, who they are. And then also we're going to, after we see this video, actually going to be 2 videos I'm going to describe, are there solutions that either brought out by the video, some discussion that relates to the challenges that this family is dealing with within their situation. And it's going to be pretty much open. The 2 videos, it's going to take about a half hour, so I don't have to talk a whole lot, all right? But I won't need to, because the video alone explains the things I think that will impact you in terms of the situation this family is going through. Okay. And real quickly, the sandwich generation are those that are caring for not only their children, but also their parents. All right. It's not really new. The reason why it seems relatively new, first of all, is because there's technology out there that has put a face on it. All right. The videos are enough to show that this is an important issue, because there are over 22 million people in America in this kind of situation. And whether or not that's accurate enough, how do we know that? Is it through home health agencies that are hearing from them? All right, well, how is all that assessed? Well, somehow the numbers all get put together, and the estimates are somewhere between 20 and 22 million Americans. And it's been increasing, not only because obviously there's more older parents out there. Mothers are in older stages as far as their ages of their children, and they're still having parents in older ages that have increased risk for dementia. Okay, the distances. Obviously we know that we're more mobile. Okay, we're not so much living next door or upstairs from our parents as much anymore. Some may be in California while your parents are in New York. All right, and how is that going to impact whether or not you can provide care for your parents if they're having issues with Alzheimer's, for example, and at the same time continue to take care of your children and have a career and take care of your household and your finances and your own health and your own enjoyment and quality of life. Not easy. There is more support for children. All right, so it gives the parents, the mothers, the fathers of the children, an opportunity to say, well, I could back off a little bit from what I have to provide for my children, so I could put more time and effort into caring for my parents that need me. All right, it seems right, because there is more support there, but it doesn't do the whole job. More working women. All right, before it was fine that it was the daughter, the spouse would be taking care of the older parent. So if they're working, how does that impact whether or not they're able to be in that role? Will they be able to work from home, for example? Okay, and then of course more people within this situation simply because of the numbers within the baby boomer generation. Okay. As far as this is pretty well known. Those that provide the most amount of care or be caregivers are usually over 50% the daughter or the wife, all right, as opposed to about 20% of the son or husband. And how big is it? Well, okay, it depends. There's different types of sandwiches that we're going to talk about in terms of the complexity of the sandwich. Whether or not they can actually live together in the same household. How much financial support are they actually receiving? That may depend whether or not they want to have that option of care for their parent instead of a nursing home option or assisted living option, if that even is an option. Many of the times that you'll see on the video, the big thing is they just didn't feel the best care that this person's father could obtain based on his health was in a nursing home. They just didn't want to do it, and they did whatever was needed to do to support and help their father in their home. Okay. How much time is actually spent on assistance? How much do they reach out for other sources of care, other things that may relieve them, whether it's respite care? We saw all these resources there. How much do they trust those resources, and how much do they really utilize them? I'm not sure about special circumstances, but I'm sure there's so many different types of circumstances that the sandwich generation falls under that they'll become evident over time. So the traditional sandwich is, as we said, you know, the children caring for both aging parents and children, but it can get more complicated. All right, with a club sandwich, the adult children are not only caring for aging parents, but they may have grandparents that they're dealing with. There may be parents on both sides of the spouses. All right, it can get that much. And then what are the conditions, or maybe there's health issues of the children that they are also dealing with. All right, so there's a lot of complexities here. I always love the open face sandwich. You know, bring everybody in. You know, it's like a big Italian family. You know, the whole family comes in and takes care of everybody. So everything's out there. Okay. As far as understanding the issues and whether or not you could even begin to figure out if there is some kind of solution to whatever the family is dealing with, there's logistics. The amount of time that they have to spend not only with parent and with their children that they're being torn between, but also for their own health and their own enjoyment. Amount of distance, whether or not they can leave where they are and move into where the parent is, or can the parent leave their home and move to where they are. Those types of things come into play. Financial issues are obviously huge. There's education for the children, your general living expenses. Are they at a point where they were also maybe thinking about retiring? They can be in that situation. You can retire earlier, you know, and still have a parent in poor health that you need to care for. And then how do you assess the needs? Are they equipped to take care of the needs in their own home? Okay. Then more social issues. All right, the relationship between the spouses. All right, and that's stress. All right, just in whether or not they could do this together as a team, because that's the only way it would work. How do the children feel about this? Are they feeling neglected? Are they feeling like they're sharing too much of mom and dad's time caring for grandpa? All right, and then if there are other siblings that maybe the wife has a brother or another sister, are they willing to share some of the responsibility? And not only are the siblings willing to, but is the wife who is taking on as the primary caregiver willing to share the time with dad with the other siblings? Okay? That's okay so far? Okay, it's all pretty straightforward. And then, you know, what if, you know, the wife and the husband who are taking on caring for their older parent were very involved with the community, or they had a working relationship at work and they need to leave that. What if they were volunteering for all kinds of things? What about their friends? How does that all fit in? Yeah. So it gets very, very complicated. But I think the video in itself will provide some of these things. So these are just some questions to keep in mind while watching it. How do you deal with the time while you're caring for an older parent, while also I need to take care of myself? It's a very, very, very big part. How much time do you give between your parents and your children? How is that decided? All right, what about for my spouse? You know, how will I recognize if I need to spend more time with my spouse? What will be really interesting is to see some statistics of marriages that don't make it in that situation. I really haven't come across that, but that would be interesting to know. And then how do I make time for myself? How do you keep that situation of not having resentment between the children and the grandparents? How do you keep that relationship strong? And who is the grandparent? Is it the same person that the children knew before the illness, for example? And then what kind of resources are out there and how do I find them? And my own feelings of like, am I in this alone? And then tons, yeah, especially if they're Italian, tons and tons and tons of guilt. Okay. So just to keep in mind as I start the video, the challenges, there are good things that come out of that situation, all right? And it'd be really interesting to recognize what they are. How does this family utilize available resources and what strategies do they use to maybe make their situation manageable? Okay? The first video shows Herbie. Herbie's the grandfather, okay? It's about 11 minutes long, and it was basically during their first 6 months when they took this on, all right? And they were gung-ho, they were, they didn't know what they were getting into, but they were mentally ready to do whatever was needed. All right, the second video, Living with Herbie, is a year later, okay? And to see what happened basically within that year's time that's changed. Okay.
Herbie, I got a phone call from Shan
Shan,
that you refuse to go home.
That's why I booked.
What town are we in now? Do you know?
That's a bad question. I can't remember it for the life of me. Yo.
Yeah.
Where is that lady? Oh, there she is.
My grandpa has dementia.
What does that mean?
He's crazy.
Is it possible at all to continue with into the wedding?
I'm doing yoga in the living room. You gonna come do yoga? Oh, you got that Einstein look going. You didn't tell me you were a mad scientist. We're full thrust into the sandwich generation. It's people who are taking care of their children and taking care of their parents. And apparently I'm one of something like 20 million Americans who find themselves in that position. You have it? I want you to do it yourself. As much as you can, you do yourself. Good. We uprooted our lives and we moved it 3,000 miles in order to be there to support my father. It's like a prime time of my life, and I basically gave it away.
He can still, most days, most meals, feed himself, although he needs help. He can watch TV, but he can't use the channel changer. He's pretty helpless in a way.
His physical needs are actually going to get greater as time goes on.
Okay, go ahead, you can sit down. Oh, are you okay? All right. The kids are being given this lesson, this life lesson, and what it means to care for someone, what it means to come through for someone else.
It's pretty cool having my grandpa in the house with us, but it's a little stressful for my parents.
It's enriching. I will have no regrets when I look back on this, but damn, it's hard while you're in it. We're about to sell my dad's house, and he's been in that house for about 40 years. I think it took a huge toll on him.
To realize that it's not going to be the same.
Yeah.
This morning when we went downstairs, we found him on the floor. And he'd probably been on the floor for a number of hours.
Herb has gone into a free fall since he went into the hospital. We're right now at a loss of how to deal with his medical condition.
I don't know how long we will be able to handle it at home, quite honestly. I don't know how we're going to function and, maintain our lives, as he slips.
Should I say the truth?
Absolutely.
Because last year I didn't say the truth.
What did you say last year?
Well, I said that it's cool having Grandpa around because I forget kind of. I think it's good that he's living at our house because he's getting old. So it's so we can take care of him better.
So what wasn't truthful about it?
It's cool having a grandpa around because that's the only grandparent I have right now. But when Poppy moved in, a bunch of things changed in the house.
When we started taking care of my father, I guess I might have advised people that they should try to take care of their parent under their own roof because I really thought that was the best way to do it. And I think that now, a year into this, I don't know if it's the best way because it's so big.
3 years ago, we moved from San Francisco to New Jersey so we could be there for him. And we are firmly committed to having him live his life out with us in our home.
I have one brother. My father did go out to California to stay with my brother for about 2 months over the winter. And I am incredibly grateful for that because it was way more than I ever expected.
Hey, Dad, you want to sit down? Hey, Dad. Dad, you want to sit down?
Come on, fold, come on.
We're full thrust into the sandwich generation. The sandwich generation is people who are taking care of their parents and their children at the same time.
Right now in this house are my mom, my dad, me, my sister, my grandpa Herbie, my grandpa's caretakers.
Hey Herbie, don't look at me like that.
What town are we in now?
That's a bad question. I can't remember it for the life of me.
My grandpa is 84 right now, and he has a lot of trouble by himself and needs a lot of attention.
About a year and a half ago, I felt that my father had hit a point that he could no longer live alone. We mutually decided that he would move in with us.
Grandpa has dementia.
What does that mean?
I don't know. He's crazy.
Is it possible at all to have continuous into the winter?
To have a what, Dad?
When it's kiss in the winter.
In this time period, we've seen a pretty dramatic change in his condition. Within a week or so, or 2 weeks of moving in, he fell, and we went through a pretty traumatic period where he went to the hospital, and then we got him back and sort of built up his strength and cognition to some decent level. He can still, most days, most meals, feed himself, although he needs help. He can watch TV, but I don't know, he can't use the channel changer. He's pretty helpless in a way.
I have no questions whatsoever that having Herbie live here means he's getting the best care he can possibly have.
And also, there's the financial aspect to this. It's already costing a tremendous amount of money every month to care for him, and we're doing it in a relatively inexpensive way compared to institutionalizing him.
I sold his house last year, so that gave us the assets to pay for his caregiving.
Yep, big guy.
When my father first moved in, Isabel was a little scared of him, and she didn't want to kiss him. She barely wanted to touch him. Isabel has gotten so comfortable that she brushes his hair. I think both kids like having their grandfather in the house.
Here you go, Herbie.
And I think both kids like the fullness of our house. Our house is never quiet.
Yep. I like the head moves. Do the boxing.
That's important for living and having kids that keep you young.
Coming at you in the stomach. Is that enough?
I think so.
Clearly, the children make him feel good. And there are times when he's gotten tense or agitated where I've even said to the kids, go to Poppy and give him a kiss, give him a hug, touch him, just so he'll know you're there, because I have to believe it's a calming effect.
I think the kids are better than the medications that he's on.
True or false? The deepest diving mammal is the sperm whale, which can It's Ruth. Hello?
Herbie doesn't do a lot for himself, but as soon as he knows he has a date with Ruth, his girlfriend, he's not jumping out of bed, but it motivates him to do a lot more.
Poppy, it's Ruth.
Hi.
My relationship to Herbie is lady friend. We've been together for 11 years, and we've had a lot of fun. He was very, very savvy and sophisticated and likable. Everybody liked Herbie. He was good to me. I cared for him. I still do. And no matter what happens, I will always be there for Herbie. Our relationship now is we're friends. I see Herbie approximately once a week. I make sure that I do that. I'll see you this weekend. Okay? Bye-bye. Bye, Laura.
Okay.
I'll talk to you. Bye-bye. And what do? Nothing.
Okay,
Sometimes it just breaks my heart.
Dad's girlfriend made it very clear early on that she did not want to be his caregiver.
As much as I care for Herbie, I was unwilling to take the responsibility of his health care.
I think I have gotten less cavalier over the past year. I stepped up to this responsibility feeling like I can handle this. And there have been so many times that I just think, I can't handle this. This is too much.
Why are you in bed?
Well, I let myself get so run down that I now have pneumonia. I think I was just pushing too hard between work and the kids and Dad and managing the house. And I got sick.
Our marriage has not been helped by this, but I don't see it as some tipping point either. I think this situation has had a more profound impact on my relationship with my children.
I was planning to go to Eli's baseball game. It's 8:20. The game started at 8.
How long does it take to get there?
20 minutes, half hour.
I'm sure you could find someone to bring him home, Judy. This is more important.
Yeah, well, I feel like I keep letting my kids down, letting everybody down.
Whenever I think I have my mom or dad's attention, then it just goes away like that because Poppy needs something. And I understand that he does need it, and we have to be there to give it to him, but sometimes I just feel like he could do it himself.
What I worry about is that, it's like a certain conditioning where they've gotten used to the idea that there are times where they might need us, but they don't even ask anymore because they know we won't be able to come through for them. Day to day, you're just being hammered, and then you're just like, your head's just spinning, and you don't actually have time to appreciate the absolute joys that are in this house, which Herbie is a part of.
My father has a beach house, and he goes out to his beach house as much as possible in the summertime with a caregiver.
He is definitely happier when he's in Fire Island because the house is his. Fire Island is like something where he still has the ability to be a man.
When my father goes to his beach house, it is amazing how much space it creates in our lives. Somebody said to me, you have to look at caregiving as a marathon, not a sprint. And I think when we took this on, we thought we were signing up for a sprint. I don't know if it's possible to fully keep your sanity in this situation. Our lives would be a lot easier if I gave up my career. I'm afraid that if I gave up my work to make all of our lives calmer, I would be suicidal. I'd be so depressed. Today's Wednesday.
It seems to me that it has become a little overwhelming to his daughter and his whole family because of the enormity of the responsibility.
Wow. Hey, what's going on here? What's going on? Herbie, I got a phone call from Shan that you refuse to go home.
That's why I booked on my mother.
I don't know what happened once I parked. It was time for him to get out. He was just like switched.
Sweetheart, what do you want to do right now?
Today is the worst.
Do you know where we are?
Yeah.
We're just 3 doors down from our house.
What do you call it here?
Mm-hmm.
Shan is her name. Shan is her name.
Okay.
She's been taking care of you for 2 years, Herbie. 2 years. I absolutely lose my temper with Herbie because I also have a certain amount of resentment towards him. However irrational it may be, I absolutely have that, and I'll readily admit it.
I've done nothing.
Well, nobody accused you of doing anything, Herbie.
Yeah.
We just want to get you home.
You mean now?
Yeah.
Okay. Yeah.
Every single day, I watch him slip away a little more. And the bottom line is, the man that's living with us now isn't my father.
There's very little of the old Herbie left. There's a vacant look in his eye. When there used to be a twinkle, it's vacant.
When you have that reality in front of your face every single day, on the one hand, it's enriching, but then there's a sort of emotional level where it is corrosive to have someone in your house that you're watching deteriorate.
Want to help Grandpa? Okay. Ready? Grandson's going to help you.
Ready? 1, 2, 3.
Wouldn't it be a shame if the kids were now left with this idea that growing old means you lose your mind? And I have to constantly remind myself that this is not the only way that people age. There are lots of people in their 80s and 90s who are super sharp mentally and who are still somewhat agile physically. Every time I bound up a staircase at 3 stairs at a time, I think, how much longer am I going to be able to do this? When I exercise in the morning, I'm determined I have to do 20 push-ups every morning. What's going to happen the day I can't do 20 push-ups anymore?
I feel sad for Poppy, do you?
Yeah, because there's nothing that he can really do that can stop the dementia. It would just be a whole lot easier if he didn't have it.
Frankly, we were never prepared for any of this, so when you ask, are we prepared for what might come next for Herbie? No. But will we come through? Yes. And we'll figure it out.
I want to show up for my father the same way he has shown up for me my whole life. There was no question for me about taking care of my father because I love him. And I would want the same for myself. There isn't a day that goes by that I don't think about moving my father out of the house. But I just couldn't do that to him. We've made our decision to take care of him, and we'll see it through till the end.
Please fill out your evaluation forms and we'll just wrap this up. All right? Thank you for being here.
Thank you. Thank you, Tony. Everybody enjoyed it very much.
Thank you, Mark.